Hello everyone, welcome to my YouTube channel. Today we are diving into the topic of mechanical ventilation. So mechanical ventilation for the cardiopulmonary patients as a physiotherapist point of view. So this outlines mechanical ventilation for cardiopulmonary physiotherapists. Our key goal are to understand the fundamentals and terminology of mechanical ventilation, differentiate between common modes like VCV and PCV and the implications for physiotherapy, identify key ventilator parameters to monitor during treatment, and integrate ventilator management with the physiotherapy goals in the ICU. Yeah, coming to empathy, let's talk about the human side. So empathy for the machine breathing experience. Patients often feel a loss of control as the machine dictates their breath rhythm, depth, and timing, which can be suffocating and lead to ventilator dysynchronicity, fighting the machine. So there's a discomfort from the endotracheal tube, inability to speak or swallow, and dry air. Communication becomes a barrier. Experiencing or expressing "I am scared" is nearly impossible. And then there is a weaning anxiety, the fear that their lungs won't be strong enough when support reduces, and it's a challenging journey. So define what is mechanical ventilation. So it's a machine, it's a ventilator performing the work of breathing for patients who cannot sustain it on their own. The primary goal is to provide adequate gas exchange, improve oxygenation and remove carbon dioxide, reduce the work of breathing to let respiratory muscles rest, and support the organ function by ensuring oxygen delivery to vital organs. So this is the foundation of ventilator support. So coming to ideate the patient clinical reasoning with the ventilators. So now let's ideate the patient clinical reasoning. Scenario 1 is nothing but a post-operative cardiac patient with atelectasis, low lung volume and basal collapse on X-ray, on volume control ventilation. So sit them up to improve diaphragmatic function and use lung recruitment with manual hyperinflation or ventilator maneuvers. So watching plateau pressure to avoid over distension. Scenario 2 is nothing but a COPD patient with dynamic hyperinflation struggling to trigger the ventilator, possibly on pressure control ventilation. Perform airway clearance with AZBT and suctioning, and during weaning, coach prolonged expiration and pursed lip breathing to reduce the intrinsic PEEP and ease breathing. So it is nothing but the ITO physiotherapy process flow chart. So it starts with the patient approaching the ventilator patient, the physiotherapist approaching the ventilator patient. So followed by a pre-intervention ventilator check, which is followed by the integrate with the clinical picture, plan and execute the PT intervention. So monitor ventilator response during the treatment, and finally do a post-intervention reassessment. This structure approach ensures safety and effectiveness of the patients. So it's nothing but the picture. The endotracheal tube goes through the patient's mouth into a windpipe or a nasogastric tube through the nose into the stomach. The ventilator blows air and with increased oxygen into the airways, while the humidifier warms up and moistens it. Exhaled air flows away. This setup is critical for patients' support in ICU. So deep dive into the concept of common ventilator modes. So fully controlled modes where the patient does not need to work includes volume control, delivering a preset volume, pressure varies, and pressure control as well. Delivering a preset pressure for a set time, volume varies. For patient these offer control, but tidal volume can drop if the patient complaints worsens. So support modes include pressure support ventilation, where the patient triggers breath or ventilator assistance, ideal for weaning and mobility. With support titrate down as strength improves. So synchronized intermittent mandatory ventilation provides set mandatory breaths with additional spontaneous breath supported by pressure, which is flexible for patient needs as well. So coming to the key parameters and alarms for patients. So it's nothing but a high pressure alarm during cough or suctioning needs investigation. Low volumes or pressure indicates a leak or disconnection. So monitoring these is crucial during therapies. So nothing but it's MCQs, and I wanted you to answer these MCQs down below the comment section. Yeah, this is one more MCQ. So, and that's it for today's session. Thank you for watching this insightful journey into the ventilation. So do not forget to subscribe, like, and hit the bell button.